The first time I saw her, everything in my head went quiet. All the tics, all the constantly refreshing images just disappeared. When you have obsessive-compulsive disorder, you don't really get quiet moments. Even in bed, I'm thinking, then lock the door yet, wash my hands, lock the door yet, wash my hands. When I saw her, the only thing I could think about was the hairpin curve of her lips, or the eyelash on her cheek, the eyelash on her cheek, the eyelash on her cheek. I knew I had to talk to her. I asked her out 6 times in 30 seconds. She said yes after the third one, but none of them felt right, so I had to keep going. On our first date, I spent more time organizing my meal by color than I did eating or fucking talking to her. But she loved it. She loved that I had to kiss her goodbye 16 times or 24 times if it was Wednesday. She loved it took me forever to walk home because there are lots of cracks on our sidewalk. When we moved in together, she said she felt safe, like no one would ever rob us because I definitely locked the door 18 times. I'd always watch her mouth when she talked, when she talked, when she talked, when she talked, when she talked. When she said she loved me, her mouth would curl up at the edges. At night, she'd lay in bed and watch me turn all the lights off and on and 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 off. She'd close her eyes and imagine that days and nights were just passing in front of her. Some mornings, I'd start kissing her goodbye, but she'd just leave because I was making her late for work. When I stopped at a crack in the sidewalk, she just kept walking. When she said she loved me, her mouth was a straight line. She told me I was taking up too much of her time. Last week, she started sleeping at her mother's place. She told me that she shouldn't have let me get so attached to her, that this whole thing was a mistake. But how can it be a mistake that I don't have to wash my hands after I touch her? Love is not a mistake. It's killing me that she can run away from this and I just can't. I can't go out and find someone new because I always think of her. Usually, when I obsess over things, I see germs sneaking into my skin. I see myself crushed by an endless procession of cards, and she was the first beautiful thing I ever got stuck on. I want to wake up every morning thinking about the way she holds her steering wheel, how she turns shower knobs like she's opening a safe, how she blows out candles, 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 blows out. Now, I just think about who else is kissing her. I can't breathe because he only kisses her once. He doesn't care if it's perfect. I want her back so bad. I leave the door unlocked. I leave the lights on.
Obsessive-compulsive disorder is one of the most frequent and serious psychological disorders. With a prevalence rate between 1 and 4%, a median age of onset of 19 years, and a chronic course, OCD can have crippling effects. Neil Hilborn's poem highlights the 2 main aspects of obsessive-compulsive disorder according to the DSM-5, obsessions and compulsions. Obsessions are the recurrent and persistent thoughts, images, or urges that cause marked anxiety or distress. Compulsions are repetitive behaviors that the individual feels driven to perform in response to an obsession that are aimed at preventing or reducing distress or some dreaded situation. People with OCD develop complex rituals that take hours every day to complete, therefore causing severe impairment. Like Neil, some people with OCD also present with Tourette's syndrome or motor tics, which is indicated as a specifier in the DSM-5. Like all mental disorders, there is no single cause of OCD. Instead, a combination of psychological, biological, and environmental factors compounded with an individual's vulnerability leads to the development of OCD. There are 2 main theoretical models, the cognitive model and the behavioral model. The behavioral model, based in classical conditioning, theorizes that people with OCD learn to avoid or neutralize certain objects or situations that they associate with fear. Mauer's 2-stage theory is a behavioral model maintaining that there are 2 distinct stages of learning fear and avoidance. Acquiring a fear occurs when a neutral stimulus becomes a conditioned stimulus through repeatedly presenting the stimulus with a feared object or event. After the fear is acquired, an individual develops avoidance behaviors to reduce their anxiety. This process often occurs amid stressful life experiences, thereby combining psychological and environmental factors. Cognitive models are also crucial and have gained much attention in the past 30 years. While behavioral theory focuses on learning and fear associations, cognitive theory focuses on the ways in which people with OCD misinterpret their thoughts. Cognitive theory aims to identify intrusive thoughts and assumptions and then modify them through treatment. There are 2 main beliefs in many people with OCD that may develop during childhood: an exaggerated sense of responsibility and self-blame. In 1985, Tsiolkovsky's proposed 5 dysfunctional assumptions that characterize people with OCD. These assumptions associated with OCD do not have to be present in each individual presenting with the disorder, but overall, they outline faulty cognitions that differ between individuals with and without OCD. Note that faulty cognitive processes are mostly examined not for their abnormal content, but for their abnormal context. Typically, the content of the obsession is less important than determining why it occurs and how to prevent it. In addition to these psychological factors, there are biological factors associated with the development of OCD, including insufficient levels of serotonin, abnormal activity in the cingulate gyrus and other brain structures, and certain genetic factors. To date, of all the drugs that have been tested in double-blind studies, research indicates that SSRIs are the only effective anti-obsessional compounds. This indicates that deficiencies in serotonin may contribute to the pathophysiology of OCD, although with additional studies, scientists may be able to better understand how serotonin and other neurotransmitters contribute to OCD. In terms of the brain itself, some hypotheses emphasize abnormal brain structures that may contribute to the pathophysiology of OCD, especially in the orbital frontal lobes and anterior cingulate region. A study by Thomas Insel indicates that the anterior cingulate region may contribute to producing the symptoms of OCD. However, Insel concluded that additional functional brain imaging and positron emission tomography studies are needed so that scientists can better understand the role of the cingulate gyrus and other brain structures, like the amygdala, in the etiology and maintenance of OCD. Abnormalities in certain brain structures have been implicated in OCD, like a small caudate nucleus, but the connection between these brain structures and OCD is not fully understood currently. Genetic studies indicate that about 22% of patients with OCD have at least one family member with OCD, suggesting that it has a relatively strong genetic component, ranging between 27 and 47% according to a 2005 twin study. Psychological and biological factors, combined with environmental factors like life stress, overly controlling or protective parents, and distress within a family, can lead to the development of OCD symptoms. OCD can be maintained through the relationship between obsessions and compulsions. Unlike a phobic physical object like a spider, a person with OCD cannot avoid their intrusive thoughts. By attempting to avoid or neutralize thoughts, the individual actually increases the frequency of the thought in the long term. This is part of why OCD has a chronic course and can become very severe if untreated. The symptoms of OCD may wax and wane over time, but they rarely disappear completely. Returning to Maurer's two-stage theory, Rockman and colleagues demonstrated that Maurer's theory not only helps explain fear acquisition, but also how compulsions are maintained. Through a series of experiments, Rockman and colleagues demonstrated that there is a functional relationship between obsessions and compulsions. Obsessions increase distress, and the compulsions then reduce this distress, at least in the short term. Compulsions are negatively reinforced because they reduce the anxiety associated with obsessions, which results in a cycle of increasingly severe obsessions and compulsions. Another maintaining factor is thought-action fusion, in which individuals come to believe that simply thinking an action is equivalent to carrying out the action. This is a learned process that functions to increase the severity of intrusive thoughts and leads to debilitating fear. There is also a high rate of comorbidity between OCD and other psychiatric disorders, predominantly anxiety disorders and unipolar depression. OCD is commonly misdiagnosed because it is comorbid with and similar to other psychological disorders. It is imperative that OCD is treated because it does not often go away on its own. Unlike in Neil Hilborn's speech, love is not a treatment for OCD. Luckily, there is an empirically supported treatment for OCD with an 86% efficacy rating called exposure and response prevention. Along with ERP, there are two other main treatments, serotonergic medications and psychosurgery. OCD was considered treatment-resistant until the mid-1960s when ERP emerged. ERP is a type of cognitive behavioral therapy that involves continued exposure to obsessional cues and procedures directed at preventing rituals and compulsions. Exposure can be done in real-life settings in which a patient has prolonged contact with external or internal feared stimuli, which is called in vivo, or exposure in one's imagination, which is often done with a therapist. According to a recent study, exposure in vivo combined with exposure in imagination is better than exposure in vivo alone. Overall, CBT incorporating ERP is typically the first line of treatment for OCD, although some individuals are unwilling to undergo this psychological treatment. Another treatment for OCD is medication, which is most frequently serotonergic. The most popular medications for OCD are clomipramine and selective serotonin reuptake inhibitors. These drugs typically produce 30 to 40% reduction in OCD symptoms, which is lower than the efficacy for CBT and ERP. In addition, the amelioration of OCD symptoms typically lasts only as long as the patient takes the medication. A much more extreme treatment is psychosurgery, and it is used as a last resort. Psychosurgery involves a surgical lesion to the cingulate bundle, and it benefits around 30% of patients. It may be used for seriously ill patients with no other solution. However, psychosurgery can have very serious side effects and is therefore more controversial and less commonly used than ERP and medication. Another less dangerous option is deep brain stimulation. A 2013 study by DeHaan and colleagues indicates that DBS may affect patients in different ways than medication and ERP. Some patients report that DBS not only improves their OCD symptoms, but also positively changes the way they experience the world. Future research may help demonstrate why DBS works and its possible benefits. According to a review of the treatments of OCD by Franklin and Foa, the most important next step for treatment is the dissemination of highly effective psychotherapies like ERP to a greater number of individuals with OCD. With current treatments, OCD symptoms can be managed and many people can function in their daily lives. But as we learn more about the human brain and develop new treatments through research, our knowledge of OCD will likely change, and so will our approach to treating it.